afternoon and welcome to today's webinar on strengthening trust and equity in primary care. My name is Sarah Greeno. I'm the Policy Director at the PCC. For those who are more familiar with our former name, the PCPCC, we were excited to announce back in the fall a rebrand. We've moved to a shorter name, the Primary Care Collaborative, or PCC. So a quick introduction to our organization. We are a national nonprofit membership organization that works to advance primary care as we see it as the essential foundation of a high-performing health system. We accomplish this by engaging and unifying diverse stakeholders, disseminating research, sharing best practices, and advocating for public policies that support the growth of a comprehensive patient-centered primary care system. So I'm going to pause for a second and just remind everyone on the line and our speakers to please mute themselves when they're not speaking. Great, thank you. So today we have over 60 organizations that are executive members committed to our mission, as well as individual supporters from across the country. A quick background about membership. We have the opportunity, members have the opportunity to participate in work groups around policy and other programmatic areas, as well as engage in networking opportunities and to gain exclusive content online and via workshops. Members also receive support and leadership from PCC to respond to critical issues in primary care that affect their members, constituents, and participants, patients. So, again, I'm still hearing a little background noise, so I don't know if, again, just a reminder to please mute yourself if you're a speaker. A couple housekeeping reminders. All lines are automatically muted. Please use the chat feature to type in your questions. Well, we'd love to hear from you. We have too many folks on the line for others to speak up. So please use the chat feature to type your questions. Questions will be addressed after all three speakers have presented. We've reserved time at the end for that, so please jot down your question or send it in the chat box. And the webinar is being recorded, so all slides and the recording will be available within the next 48 hours or so. So I'm personally very excited about today's topic. We really have a wonderful panel of speakers who have deep experience and expertise around issues of health disparities and or trust, or really mistrust, and how it affects how care is delivered. I will let our moderator for today introduce each speaker individually, but before we jump in, I think it's important to acknowledge one voice that is not part of today's discussion, and that is one of the patients. As the panel came together, we were limited by how we could squeeze everything into 1 hour, and our team at PCC recognizes that patients are absolutely critical to a conversation around trust in the healthcare system. So we're planning a follow-up webinar that will address many of these same issues, but from the perspective of patients. I welcome if you think of names, please feel free to send them our way. We're in the beginning stages of planning and some more details to come. So with that, it's my great pleasure to introduce Jennifer Edgoose as today's moderator. Jennifer is Associate Professor in the Department of Family Medicine and Community Health at the University of Wisconsin School of Medicine and Public Health. She focuses her attention on the care of vulnerable populations and strategies to promote health equity and community engagement. Jennifer also serves as a core member of the Health Equity Team for Family Medicine for America's Health, a national strategic planning body shaping the future of family medicine nationally. She has practiced full-spectrum family medicine for over 10 years at Community Healthcare, a federally qualified health center in Tacoma, Washington. Jennifer, with that, I'll turn it over to you.
Thank you, Sarah. I'm very excited today to moderate this important dialogue on the intersection of trust and health equity. According to the Merriam-Webster Dictionary, trust as a noun is the assured reliance on the character, ability, strength, or truth of someone or something. And as a verb is to rely on the truthfulness or accuracy of something or someone. What is so beautiful about trust is it implies two sides that are bonded by faith in the other. Trust is an essential component as we strive to achieve health equity, as health inequities are a classic wicked problem that involves multiple stakeholders needing to work together, and perhaps most importantly, needing to work with those groups that find themselves on the wrong side of the disparity equation. For those of you wanting more resources to help teach about health equity, I wanted to introduce you to this link to the Health Equity Curricular Toolkit that is now housed on the American Academy of Family Physicians website. In collaboration with 40 other interprofessional thought leaders and educators around the United States and Canada, we have developed this resource that was supported by the Health Equity Team for Family Medicine for America's Health. You'll find a guidebook and supplemental videos and videos for facilitators and their learners, and 14 modules focused on broad categories of social determinants of health, vulnerable populations, and economics and policy related to health equity. This is currently being evaluated by the American Academy of Family Physicians National Research Network at 3 academic institutions, but has been released for general use due to its timely nature. Oops. So I also wanted to share that I've been thinking about concepts integral to trust for some time, and when we charted our department's first Diversity, Equity, Inclusion Committee in 2015, our vision statement uses trust as a mnemonic. So we start with tracking, as accountability is critical in trust, recruiting, as assuring that having a diversity of voices and ideas at the table is also critical in this work. The U is unlearning and learning. So now our residents learn not only about community engagement, but also about structural oppression, bias, privilege, and microaggression. The S is sustaining and retaining, as concepts and opportunities to promote inclusivity are critical to trust. And finally, the last T is training and transformation, where we brought other community partners to provide training for our entire department. So without further ado, I'd like to introduce us to the rest of our speakers. So we are going to be led by Dominic Mack. Dominic is a professor of family medicine at Morehouse School of Medicine and serves as director of the National Center for Primary Care, where he oversees a portfolio of big data health equity and health services research. He's a founding director of the Georgia Health Information Technology Center and Georgia Health Connect Health Information Exchange. Dominic spent over 20 years practicing medicine and providing medical leadership in metropolitan Atlanta, with many years of service in the qualified health center system. Dominic will be followed by Evelyn Figueroa. Evelyn is a professor at the University of Illinois College of Medicine, Family Medicine Residency Program Director, and is the director of the University of Illinois Health Pilsen Food Pantry. She focuses her primary care practice in vulnerable populations work and direct service learning programs in homelessness and food justice, in addition to leading bias in healthcare educational sessions for her department. Evelyn is also the executive co-director of the Figueroa Wu Family Foundation, a nonprofit organization that conducts anti-poverty work. She's been honored with multiple awards for her social justice teaching and advocacy. And finally, Daniel Wolfson joins us as Executive Vice President and Chief Operating Officer of the American Board of Internal Medicine Foundation, a not-for-profit foundation focused on advancing medical professionalism and physician leadership to improve the healthcare system. Previously, he served as President and CEO at the Alliance of Community Health Plans, where he helped spearhead the creation of HEDIS, the Healthcare Effectiveness Data Information Set, and as Director of Planning and Research at the Fallon Community Health Plan. Daniel has a master's degree in Health Services Administration from the University of Michigan School of Public Health. So thank you all for joining us, and I'll turn this over to Dominic, who will be speaking first. So thank you.
Thank you, Jennifer. Today, I'd like to talk to you all about aims and trusts in U.S. healthcare and ask the question, are we leaving the underserved population behind? I'd like to say good day to everyone and thank you for attending today. I'm on a great team at the National Center for Primary Care, which is one of Morehouse School of Medicine's core centers and institutes. Our 4 divisions, Health Information Technology, Policy, Substance Use, and Prevention and Research, develop scientific programs to strengthen the U.S. primary care infrastructure and support optimal population health and health equity for all communities. Today, as we talk about trust and equity, I would encourage us to think about national aims for healthcare transformation in the United States. Just as this transformation centers around cost, convenience, and quality of care, so does our conversation of equity and trust. Trust of the patient, trust of the providers, and trust of the general population in our healthcare system. If you look at this, we have many aims to improve health equity and trust within the community, but there remains mistrust, and a lot of the mistrust are around some of the issues that you see on this slide. So let's talk about health equity, trustworthiness, and underserved communities. First, let's look at the current practice environment. We practice in the world of high tech, ACA and Mack. These are federal laws and programs that have significantly impacted the healthcare infrastructure. I believe these were and are sincere efforts to improve the quality of care and assure health equity for all Americans. A strategy based on evidence and requiring new technology, certification, and quality measures within the healthcare system. These programs have already transformed the way we practice medicine. For example, if we look at high tech and CMS's EHR incentive program, billions of dollars were paid to providers and hospitals to advance the adoption of digital health, and this has been a successful stimulus. Millions of dollars in support have also been put forth to help practices adopt QPP, MACRA, for better quality and better patient engagement. So whether we agree with the methods or not, great efforts have been put forth with the aim of achieving equity and trust in the U.S. health community. But there remains a health problem. There's a known fact that good intentions do not always result in good outcomes. One example that has proven true in healthcare is the proof that practice innovations can often widen gaps and disparities. AHRQ Annual Healthcare Disparities Report stated that improving quality for all does not necessarily reduce disparities for racial and ethnic minorities. The diagram shows that equity and quality can overlap, but the meaning is not synonymous. This is most evidence in the United States. The World Health Organization found that the US ranked poorly among other countries when it comes to population health. Most of the healthcare costs in America is connected to underserved communities, with citizens who are more likely to be at the lower economic scale and have multiple chronic diseases. This and other research act as supporting evidence that poverty and poor health are strictly linked. This is actually a picture of Medicaid and Medicare and the penetration within the United States. Patients with multiple chronic conditions cost up to 7 times as much as patients with only one condition. And these are the people who account for a disproportionate amount of our Medicaid and our Medicare cost. I'm clicking, but it's not moving. Let me try it again. Slide's not moving. Okay. There's also growing health disparities among our growing population of seniors who consume a disproportionate amount of care within our health system. By the year 2015, the US will have over 19 million seniors over the age of 85, as seen in blue. In a 2013 study, nearly half of elderly had incomes twice the poverty threshold. So we used to look at folks who retired as being comfortable, but a good number of elderly are actually in the poverty level, at poverty level. Let me go back one. When we look at primary care and small practices, which have traditionally taken care of underserved communities, the financial and practice management burdens of quality measures and technologies have led to the closing of small and even larger practices. And unfortunately, the adoption of technology has left behind the specialty that may be the most in need, which is psychiatry, a field which has led significantly in the adoption of electronic health records and digital health overall. Disparities in quality and practice was reported by AAFP in 2015. The Graham Center's one-pager reveals that smaller practices are less likely to certify for PCMH. At the NCPC, we discovered that providers in Georgia who take care of high Medicaid populations are less likely to adopt electronic health record and probably make up a disproportionate amount of those providers who don't qualify for PCMH. So independent primary care practices that have traditionally cared for underserved providers have been overburdened by the same policies that were intended to improve their practice infrastructure and help with the quest for health equity. We have to ask ourselves, are we really trying to achieve equity? And we talk about trust today. So let's look at briefly how the social determinants are part of this conversation. Believe it or not, people are interested in their health within the underserved communities. We've been involved in research showing that Medicaid patients are aware of the importance of socioeconomic status and how it may affect bias in their health access and treatment. When you think about it, it makes sense because they actually live this every day. Social determinants may help us to answer the question, why do inequities remain? Some of the answer is rooted in our history. Many inequities have been perpetuated by programs throughout this nation. Here are two examples. Racism and housing policies in the 1950s led to what we know today as redlining. Another one was in 2015, Medicaid prescription discrimination for a drug that treated hepatitis C for people who had Medicaid. Poverty is linked to health. There are more kids born today in high poverty than there were in 1955. Think about the policies that allow for this type of occurrence. We went from 2.4% of Americans living in extreme poverty to 4.4% between the years of 2000 and 2014. Even though 55% of voters in one poll would agree to a minimum wage raised to $15, minimum wage remains at $7.25. Mental health and education are social factors that unfavorably impact underserved populations in many ways. These effects can burden members of the community throughout their lives. Of course, we don't have time to speak on all the factors, but even in the healthcare, there are healthcare policies that can negatively affect the health of populations. We know that health insurance can improve access to care, and if we believe care can heal, then why do we deny access to communities? In 2019, Commonwealth report shows that even though the ACA has helped to achieve a 12% uninsured rate, today 45% of US adults ages 19 to 64 are inadequately insured, nearly the same as 2010. So briefly, let me speak on some of the solutions we're looking at, and we can talk about other things if we have time for question and answers. One of the things we've developed at NCPC is our PEDAL framework, which is integrating health equity into learning health systems. We develop frameworks to prioritize and implement sustainable programs in at-risk communities. How do you approach these communities? How do you evaluate in these communities? Use the data to actually improve upon the care and decrease health disparities. We create complex methodologies in our research division to create health services and catchment area methodology. We apply this methodology to highlight the importance and effectiveness of primary care in other areas in improving health and achieving health equity. and research to show the gaps in technology adoption and the policies that may contribute to these inequities, including telemedicine and also missed opportunities in collecting patient data. And for the last couple of slides, technology, we've done this in the Southeast. We know when you go from your primary care doctor to your specialist, your medical information is not there. You hear that from doctors and from patients. We've looked at health information adoption, and we've looked at the gaps in the Southeast and how can we improve upon those gaps. And one of the things around the social determinants of health and the importance of the collection of that data is we have to collect contextual data around housing, employment, and food availability, environmental quality, and other areas. And one of the areas we're proud of is we've developed a health information exchange that focuses on underserved communities, collecting data such as data from the correctional institution, from the emergency medical systems, and other data points that can actually be integrated into the health record to improve the care of patients from these underserved communities and help these under-researched practices to provide better care. So with that, I will turn it over to Evelyn so she can do her presentation. Thank you.
Hi, good morning. I'm Evelyn Figueroa from the University of Illinois. I'm wanting to talk to you about the work that I'm doing, which is trying to help teach about social determinants, but in an academic underserved setting. I am a family doctor that has been doing this for 15 years, and I run a lot of education. And the tools that I learned in medical school are very, very helpful. Physical medicine is, of course, incredibly helpful to taking care of patients, but there's a big part of it that I feel that we have to do a better job. I think that Dominic really set the stage beautifully, talking about the tremendous systemic barriers that patients face in terms of having comprehensive whole patient biopsychosocial type of medicine. And if we're going to change policy and improve these things, I think that we have to be teaching this to kids starting at a young age to expect justice and to try on a systemic level. I can, have as many encounters directly with patients, but if I actually don't change the system, it's not going to improve. So at this point in my career, I spend a lot of time working on systems, although I still enjoy face-to-face encounters with patients. So I have no disclosures to release that are related to this. And we were going to spend a little time talking about revisiting social determinants that affect people living in poverty, and then to hear a bit about the service learning model that I've developed through my work that first started with food insecurity, and then for us to think about how what medical education, healthcare education of the future should look like. So my community, just to help get us all on the same page, my community is the University of Illinois at Chicago healthcare system, and we are a medium-sized academic institution. We have 7 health colleges, including the College of Medicine. We do 500,000 visits. Outpatient care a year, family medicine does about 10% of those, and then for emergency room visits, they're close to 50,000. We really affect a lot of parts of Chicago, but the areas that we affect the most are south and west side of Chicago, which tend to be majority non-white populations. We do surveys every few years on our community, and our uninsured rate is higher at the University of Illinois. There are significant transportation barriers. So if you look at the graphs that are up here, we have something about uninsured rate and transportation. UI Health is orange in this one. If you go below to homelessness, we don't have this for UI Health, but there are a number of encampments around the University of Illinois. And my residents do work in homelessness. I'm also volunteer medical director of a homeless clinic to try to strengthen the connections that we have in helping people have a medical home and experience better health. And then if you're looking at unemployment, you'll see that the unemployment rate is higher for UI health patients by over 50% compared to the national and Illinois rate. So it's quite unfortunately, and that of course contributes to disproportionate poverty, people on food stamps, et cetera. Chicago actually has pretty decent education. So what's interesting about this is, in spite of people having higher unemployment and poverty, the high school degree as a terminal degree is still quite notable. So you can there's a lot of research in Chicago and across the country that talks about just the effect of racism on employability and its tremendous contribution to generational poverty. And I think you at University of Illinois is a very good example. Our patients are in this dense place that needs people to work, and yet people who want to work are finding a lot of difficulty finding meaningful employment that's to the top of their ability. The national rate for Medicaid is here in the teens for the country, and if you look at UI Health, we're way off the charts. The UI Health rate is over double the national rate for Medicaid. Until ACA expanded, the University of Illinois was the top Medicaid provider of Illinois. And what's really interesting about this is that in spite of that, we had very much siloed our social work and other wraparound services for our patients. So there was a very large disconnect. And I became increasingly frustrated, and through work that I was doing with my academic organization, I really needed to up my ante and do a better job taking care of my patients if I was going to feel good about it. I felt like I was seeing the same problems again and again in my patients, and I needed to develop a higher fluency of caring for social issues that were obviously negatively impacting their health and wellness. So I really had to work harder on understanding what equity was, what trust was with my patients, the cultural differences between myself and my patients, how to be a good ally, and how to really navigate UI Health resources. I live just a few miles away from UI Health, but I don't live on the south or the west side, and I do live in a decent provider service area for University of Illinois, but it's definitely not one of the top 5 or 6. So I needed to learn about the resources that were adjacent to the patients, especially knowing that they have transportation and financial limitations. I can't be sending them all around the city. So now I do a lot of teaching that addresses racism, sexism, other types of bias in healthcare, and truly trying to help my learners of many different levels. So starting in medical school, but now I teach even in the undergrad to help them have role models and understand that we have to be part of this solution. So our main project, and this all grew around it, and this was kind of the low-hanging fruit, pun not intended, was the Pilsen Food Pantry. We started a nonprofit just over 2 years ago to address the abundant food insecurity in Chicago. 1 in 5 families is food insecure. The UI Health rate is at least that high. It really depends on who you're surveying. Sometimes you'll even get rates of 80% in certain clinics at the University of Illinois. And we don't have very many food pantries that are accessible. And the other issue with food pantries is that they really struggle to provide fresh offerings to clients. So when Dominic was speaking a few minutes ago about folks really caring about their health, I could not agree more. I think that we struggle in healthcare to be able to kind of get through our work and normalize inequity with our patients. And I think one of the defense mechanisms is for people to think that people that have worse health outcomes just don't care as much about their health. And I just have seen something so different from that. It's challenged a lot of my values and beliefs about poverty, and our patients typically, or the clients that are there, are actually pretty wonderful cooks. We do offer cooking classes and things like that, but having students and residents and undergrads and high school students and children volunteer at the pantry helps people see the face of poverty and understand that these are people who look just like us. We're open 5 days a week, and we are deliberate about that in order to increase access. It also allows us to accept more perishable foods. So this is a pretty typical day in our pantry where people can get about 60 pounds of fresh produce, dairy, frozen meat, dry beans, et cetera, whole grain things. We don't do that many cans, although we have too many cans and people would much prefer the fresh food. So, and this is really a proxy for poverty, right? If you're working with people on food insecurity, the reason that this was a relatively, it's a complicated thing to run a food pantry in terms of organization and sanitation, et cetera, and inventory management. But we have food insecurity is a problem with the solution we throw away. It all depends on the resource you're looking at, but globally about 40% of the food that we produce ends up in landfills, and that creates greenhouse gases and is one of the top 5 things you can do to improve our environment. So this was something where I could recover food. Some of the U.S. estimates are even higher than 40% of food being thrown away. So it's very much logistics. And food insecurity is a proxy for poverty. If we free up money for food, they will have money for other things. But people ask for a lot of other things, and that's the direction that we've been heading in. So last summer, we embarked on a very large literacy project with a local nonprofit called Open Books. So we have a little free library that we have at our pantry, and we intend to expand on that with some reading classes for children, et cetera. Literacy, like food insecurity, is highly linked to health outcomes. Now, because of time, I can't make much of a medical case for food insecurity improving health, but I will throw out my two statistics that always motivate me. Or I'll do 3. I'll start with literacy. So in the average household with middle-income household, there are 13 books per child. In the average low-income household, there is 1 book per 300 children. This affects children's upward mobility. This contributes tremendously to generational poverty. So when you really connect with kids before they're 5 with books, it helps. But that's also why you see all those smartphones in clinic rooms. That's because parents don't have books. So it's a real reality. And for those of you who love books, you develop you develop almost as a child a curiosity and a love for reading. If you don't develop that when you're young, you really get left behind in terms of how many words you can learn, how quickly you can read, et cetera. And of course, that translates to all sorts of financial and reading literacy and health literacy. Back to the pantry, the big statistic is about diabetes. So it's a pretty easy one. Although food insecurity is linked to many different health problems, one of the most impressive is with diabetes. So every year that someone is food insecure, they increase the risk of developing diabetes by 10 years, which means after 9 to 10 years, they've doubled their risk of developing diabetes. And you can see that if someone was food insecure and diabetic, how much even worse that would be if they are working with very limited conditions. And of course, our patients and clients of the pantry are working with limited refrigeration, cooking conditions, et cetera. It's just all related issues that unfortunately they struggle with. The Canadian Medical Association actually just released an article this month that talked about that severe food insecurity increases mortality of all causes of death, except with the exception of cancer. And the worst 3 things, even though it's worse for everything, all chronic diseases, food insecurity makes worse for infectious disease and suicides and accidents, unintended injury. So these are things that, even though they seem like unrelated social to some physicians and some healthcare workers, it seems like too much, too big to fix, but this is something where it's incredibly important for us to know our resources. And then that's really feeding into the final product of our anti-poverty work, which is actually a full community center. And that's what the last slide is about. That's our aspiration, and we'll be integrating social work services by the fall and other services, as you can see. So thank you very much for your time. I'm now going to introduce Daniel Wolfson, who's the CEO of the ABIM Foundation.
Well, thank you. Inspirational talks. Both I I take from Dominic structural inequities, and in my talk, I'm going to be talking about trust. And when thinking about trust, the structural inequities are a sure way to build mistrust. And Evelyn's talk about social determinants of health and food insecurity and literacy, I think actions that address those social issues creates trust in society. So I'm going to talk about an initiative of the ABIM Foundation. I'm going to tell you really about a journey that we're on currently. Many of you know us from our Choosing Wisely initiative, which is in our 8th year. The foundation and the foundation's board decided to address trust as an issue going forward. A large part of that I will explain, but I love this quote by Stephen Covey. This is actually Stephen Covey Jr. Trust is the glue of life. And if you think about any relationship in healthcare, it's all about relationships, and we want to strengthen those relationships, be it a patient-physician, be it physician-organization or patient organization. We want to look at all those kinds of trust relationships. But why did we get into trust? I think that we've seen a significant erosion over the past 4 decades in the healthcare system. I think there's an erosion of trust generally in society. There's been a huge attack on science and a lot of misinformation, which I think threatens the patient-physician relationship. You know, we know that trust creates better health outcomes, greater value, and it has a link to professionalism, which is really the mission of the ABIM Foundation, which is to use professionalism to as a lever to advance the quality of healthcare. So this is many sectors of society about their trust, and actually healthcare has a lot, but we're the biggest loser of trust since 1975. It's not broken out by doctor or health system, but we know that over this time period, there's been we're kind of the biggest loser in trust. So what factors, system factors are affecting trust? Oops, went too fast. Ugh. Well, okay. Sensitive. Okay, so, well, I'll just tell you what's on that slide. System factors affecting trust was on that slide. And equity, of course, is on the top of that list. But things like community integration, transparency, the environment of the institutions, leadership, research, integrity. In January 13, in an upshot, there was an article about racial bias still affecting healthcare in the United States, which you've already have heard from. But we also talk about patient. Okay. I'm going to have somebody help me with this. Okay, so I talk about the 3 C's of the patient-physician relationship. That is communication, competency, and compassion. But here are some other things that affect the patient-physician relationship. This is an article that was in the American Economic Association. Care for African Americans patients is better when they see African American doctors. That's been proven, particularly around preventive health care. And we know that 4% of physicians in America are African American as compared to the population, which is 13% or 14%. So one of the things that we did at a conference 2 years ago was looking at all the aspects of trust, patient-physician relationship, patient interest in health systems to eliminate health disparities. And this began for us an important conversation about trust that we wanted to really elevate. I think we're good at identifying issues and elevating them. And we wanted to really elevate the role of trust in healthcare because we think it's so important to health outcomes. And our journey, of course, brought us to the problems of mistrust within underserved communities, and we'll get to that. But one thing that was similar to choosing wisely is you can talk about overuse or you can talk about trust, but how do you get more concrete about it? So we developed 2 years ago this Trust Practice Challenge where we asked people to identify practices that foster trust in healthcare. And at the time, we got 68 submissions, 24 meritorious practices, and then we anointed 8 winners. They were on several aspects of healthcare, but here are 3 exemplary submissions: a use of a graphic medicine to improve patient-physician engagement involving EHR, using a simple comic strip. And one of the outputs of that was disadvantaged populations, in fact, benefited most from it. Here's another dedicated clinical program focused on the LGBTQ community, where there is a lot of distrust about using the healthcare facility, and they did training about pronouns and providing a safe space for the LGBTQ community. And then another one was sharing data. And, we think that sharing data is important. And we can talk about how that impacts, how important that is to look at data of underserved populations. So then we transitioned into what we're now calling our Building Trust initiative. And that's part of our Trust Agenda initiative. But our purpose is really to elevate the importance of trust as an essential organizing principle, build a community of organizations that are interested in addressing it as a means to achieve better health care. We're giving people these 5 simple rules, and people are developing ways they want to collect these practices, similar to what we did with Choosing Wisely. I want to go back. So this has led us to think think about health equity. If you're looking to think about trust, the area where it is most prevalent is in disadvantaged populations. We could talk about the origins of that. It has historical, as Dominic pointed out, it has structural inequities. But when we began to think about how we could begin to structure some conversations around health equity, we began to think very broadly and comprehensively. One was about the workforce diversity. How can we increase that 4% to be more akin to what the actual population is? And how can we think about workforce training? The existing population, how can we increase their awareness? How can we increase awareness about biases in healthcare? And how can we begin to think about, recruitment of the disadvantaged, underserved populations, racial, ethnic groups in research? Because we get biased results when we don't have good representation of those communities. And how can we fix evidence logarithm-based biases that creep up when people are doing logarithms that don't include disadvantaged populations? And then how can we think about practices? How can we think about quality improvement, performance improvement usually thinking about how we can collect racial and ethnic data. How can we think about the role of primary care and listening to communities and thinking about an asset-based kind of approach rather than a deficit kind of approach to primary care and how they relate to communities? And then diagnostic bias. How can we think about diagnostic bias? We know it's prevalent in gender. We know it's prevalent in age. Begin to study how it affects African American communities and Hispanic communities. And then, of course, what's been talked about social determinants of health. I think I can go over this, but I think people before me have done a better job. But 50% express low levels of trust in providers and cynicism about care decisions, citing financial influences and conflicts of interest. Some express experiencing bias on insurance. Many express desire for trusting long-term relationships. And this was a white paper that we did when we began to look at choosing wisely and how choosing wisely was being received by Hispanic and African American communities. And this is a paper that we wrote about communicating about overuse with vulnerable populations. So, there is a huge financial cost of healthcare disparities. Disparities amount to nearly $93 million in excess medical care costs. I think this is another lens that we can begin to think about the urgent need to address health disparities. There's some good papers out actually that have looked at when financial incentives go to more global payment, more focus on underserved populations occurs and significant improvement occurs. I'm having a tough time with my slides, but I'm done. And thank you so much, and hopefully there's time for questions. Thank you.
So thank you all. There we go. So thank you so much to our wonderful speakers for your inspiring talks. We certainly don't have enough time. As I'm sure many of you do have many questions, this would be a good opportunity for those of you who are listening to put any questions you have in the chat box, and I'll do my best to see if we can answer at least a few of those. I did see that some people were asking about whether the slides will be available. So the webinar and slides are available, and they will be loaded up to the Primary Care Collaborative website, the pcpcc.org website, probably within the next 48 hours. So just wanted to make sure that everyone knew you will have access to this to look at some of the slides in more detail. I think one of the questions that I saw coming up, this is Evelyn when you were talking, but it's a really interesting question when we talk about trust and health equity is, I think many of us now are well attuned to how social determinants of health are certainly driving health inequities. And so we're seeing this kind of burgeoning of desires to start screening for social determinants of health. People are trying to create interventions. I mean, obviously there's need for more evidence around this, but in the interim, to me, one thing that's always been sort of an area that I've been interested in is how do you screen for social determinants of health in a manner that promotes trust? And was wondering if you or Dominic or even Daniel, if you have any thoughts about how to do that.
Thank you. It's an excellent question. There's a lot of stigma associated with being poor. There's a lot of blame that we make on people for living in poverty. And of course, there are tremendous structural systems that for a lot of people guarantee lifelong poverty, right? So patients are not completely aware of that, especially with a lot of shame attached to it and the meritocracy myth. So the bootstraps mentality that persists in even poor communities. So when I do screen, I try to normalize it just like I would for a sexual health history, where I ask everybody these questions. I have students now that do an advocacy. So I actually work with all of the clerkship students on family medicine, and they have to do just a tiny selective in advocacy and learn to administer social health inventories. And that's some of the feedback that they've given me. With my patients, there's a ton of trust. My practice has been closed for over a decade. So if I can ask patients all sorts of, very personal questions, and they are incredibly, incredibly patient and forgiving with me. The students I've worked, that's a new thing that I've been working with the students on, just to explain to them, we're trying to take more comprehensive care of our patients. I'm going to ask you some questions. I think the nice thing that's happening through the entire EHR is some software that's coming with, for instance, Epic systems, like the NowPow software, which is helps you locate community resources. And a lot of people are just adding it on to Epic. They have a very comprehensive population health panel. So it's nice that over time, I think we're going to normalize asking a lot of these questions. I do think there's a danger of asking questions if you aren't aware of your resources. So being sure that you, if you don't have Epic and access to NowPow, a free resource is something called AuntBertha.com, which is a national database of social services.
Thank you. Dominic, go ahead.
Yeah, this is Dominic. Quickly, I'll just say, trust is important, as Jennifer stated, and she talks about the trust of her patients, but Daniel also presented evidence that showed, especially in the African American community, that they were more comfortable with people who were aware of their culture. And the study that I showed earlier showed that patients, once they're aware of the social determinants, they think they're important. So the main thing is the trust, but I think when you get the trust of the patients, they know it helps them, it helps with their health, so they don't mind sharing the information.
I think Evelyn said it the best. I think it has to do with continuity of the relationship and the trust that's built over time.
I also think that what we've done with some patients that are pushing back against it and saying, I'm not poor, I have enough food, and sort of that defensiveness that comes with it, I try to, as the professor, really remind the patient, say, this is something we're doing for everyone. I very, very much try to normalize it. And you see people, you see them get a lot more comfortable. The circumstances are important. And unfortunately, there are going to be sometimes that people are going to need to do screening in emergency rooms. So, a direct, are you homeless, is going to elicit a different response than, where are you staying right now? So it's having that sensitivity and really trying to frame your questions in a way that make it easier for the patient to tell you what their situation is. Even the order that I train the students to ask about social determinants, I don't have them ask about financial and domestic intimate partner violence until the last question, and immigration until the end of our 2-page questionnaire. And I do that deliberately because it's just too harsh of a startup with certain topics.
Great. Thank you all for those insightful answers. I saw someone mention something about urban, and I think most of us are coming from more urban environments, but as we sit here in this complex 2020 election year, I think it's important to talk about urban and rural, and wondering about how are you thinking about promoting trust across difference along those lines, if any of you are actively doing anything there. Thank you.
Yeah, this is Dominic. We do a good bit of work in the rural areas of Georgia, and one thing we say here is Metro Atlanta, then it's the rest of Georgia, and the rural folks actually don't accept a lot of the information or the efforts of people from metropolitan Atlanta because they believe we really don't know the community. So there's a little cultural divide. So we develop our programs no matter what we're focusing on in a manner where we engage, and I showed you the pedal framework, but we engage the communities. And actually, in a lot of instances, we actually hire, we let those within the community lead the programs to gain that trust, because you don't know the ills of those communities, and there are some barriers that are different. The population is different. The issues are different. We always say healthcare is local. So we're just always respectful, and we want to make sure that they're part of any type of, whether it's research or anything that we're developing, that they're part of that, and we have the representation that they will accept.
For us in Chicago, I'm a training director for family physicians, so we have a separate curriculum that talks about rural medicine, and this year we actually are launching a rural training track. We had an agreement with a rural hospital already and intermittently sent residents to practice rural medicine. If you look at the amount of physicians that train in nationally, only about 10% of them will choose to go into rural settings, even though 20% of our entire population is rural. And there are some social determinants that really don't even get counted the same way. Even homelessness is counted differently because homelessness is attached to living undomiciled or living without a house. So in rural areas, that would be very difficult. It's very difficult to have an encampment in a rural area because they are already so far away. So they're more likely to sleep in their car, sleep on someone's couch, even though the situation may be less than ideal. That actually is tied to funding for shelters, et cetera. So there are some systemic barriers to counting and addressing social determinants in a manner that would be more appropriate to rural areas. So I try to teach the residents about that, and that has become part of our curriculum for the new rural track.
Thank you. I just realized that the time is such that we don't really have time for 4 more questions here, but did want to sincerely thank all of our wonderful speakers for joining us today and sharing their insights with us. I hope you can sort of hear us all virtually clapping here in the background. And I will simply again say that this webinar and resources will all be available on the pcpcc.org website shortly. So again, thank you all for joining us, and we look forward to the next conversation that will include patient voice as well as we discuss trust and health equity. So thank you all again.
Thank you for the opportunity.
Thank you. Thank you.
Thank you.